I'm excited. It's starting to warm up today.
Yeah, but then we're supposed to get snow or frost or something, I heard.
Oh, geez.
Crazy weather.
Yeah, it's 63 degrees, but it says freeze warning because that makes sense.
Isn't that ridiculous? Okay, I have 2:57, so I'm just going to give people a couple more minutes to get in here and then we'll get started.
That's fine. I'm just playing Switch.
Okay, guys, we'll go ahead and get started. Can you see my screen okay? You guys see the PowerPoint?
Yep, looks good to me.
Okay, good. All right, so we're going to start off with this lung disorders stuff here. There's literally 3 million things we could talk about in this respiratory stuff, so I'm going to try and condense it a little bit here. So first of all, this gets into a little bit about normal lung function. So when we breathe, when we inhale air, oxygen travels into our upper respiratory system, through our nose, our nasal cavities, down through our larynx, down into our respiratory system. So everything splits off into your bronchi and into your pulmonary arteries and your veins. And then once everything gets down there, the primary bronchi breaks down into smaller airways even from there. So then air enters into your bronchioles and your alveolar ducts and your alveolar sacs. And that's where we start to do that gas exchange. So as we breathe in air, we take the oxygen from the air, we use that, we have that oxygen exchange down at the alveolar level where we take in the oxygen and we get rid of carbon dioxide that's in our body. And then, we do that gas exchange there at the alveoli. And then as far as our diaphragm goes, our diaphragm is very important. It's a muscle that helps us inhale and exhale air. So it's going to contract down, which causes a negative pressure to be in the lungs. And this allows air to rush into your lungs and it causes your diaphragm to relax back into this like dome-shaped position that it normally is in. And then with the alveolar sacs, like I said, we have that gas exchange that happens there. So that's what normally happens. So when we talk about these different disorders, usually there's a problem somewhere along those lines that we just talked about, and that's why you're having the disorder, because there's a problem in one of those areas. So these are the things that I have in this PowerPoint. We talk about asthma, COPD, pneumonia, ARDS, and then also lung cancer. So the first thing I want to talk about is asthma. And I'm not going to really flip through these slides very much. I'm just going to kind of talk to you a little bit about it. So first of all, does anyone in here have asthma?
Nope.
Okay. So basically, I don't know how much you guys know about asthma, but my son had asthma at one point. He's really not too bad with it anymore, so I don't even really consider him having it anymore. But what it is it's a chronic lung condition that can cause narrowing and inflammation of your airways. And usually this is because of some kind of trigger. And typically it's like some kind of allergic trigger, possibly. It's not always allergic. It could be other things too. So if you're writing notes here in this stuff, I would list some of these things as triggers. So smoke could be a trigger. Pollen, when you're outside, you know, and there's a lot of pollen and stuff, that could be a trigger. Pollution, perfume, dander, dust mites, even things like cockroaches, which is cold and dry air, mold, respiratory infections, GERD, hormonal shifts. This could be exercise induced, because a lot of people have that. And then also drugs can cause you to have a trigger for your asthma. So the specific drugs we're talking about would be NSAIDs, aspirin, beta adrenergic blockers, and then also certain things with preservatives like sulfites in them. So those would be some things that could trigger you to have this episode. So what exactly is happening with this is that, you know, you have this trigger and it sets off this inflammatory response that happens inside your body. So all of those airways that we just talked about, like the bronchi and the bronchioles and everything, they become very inflamed. So when you look at your airways, they are lined with smooth muscle. And that smooth muscle has the ability to relax or constrict. And during an episode of this, when you are triggered, you can have constriction happening. So not only do you have inflamed airways, but now you have this muscle that's constricting even more. And then the third thing that happens inside of all of this is we have these cells that are called goblet cells. And goblet cells are inside your airways. And what they do is they produce mucus. And so during an asthma attack, usually you produce more mucus during that time. And so now you have airways that are swollen, they're constricted, and they're full of mucus. So it makes it really hard for air to get through, you know, when someone's having an attack. So that's kind of why we hear, you know, when someone has asthma, you think immediately of wheezing, because if you think about it, as you're trying to take deep breaths in or anything, you're having a hard time because you can't get air through. Now, as far as signs and symptoms go, there's quite a few different things that you could see when someone has an attack. So wheezing is going to be your number one thing. But then you can also see chest tightness. You can see coughing. You can see an increased respiratory rate. And things that can kind of go along with this, you know, if this gets worse, you know, if it keeps going, this asthma attack, and you can't get it under control, eventually this person's going to get to the point where they can't talk anymore because they're so short of breath. And they're going to have sweating. They're going to be using their accessory muscles to breathe. And eventually they're going to have cyanosis and stuff too. So it can be a really scary situation. On this slide here, it kind of shows a picture of the airway. So here's a normal airway, and at the end, here's your alveoli and stuff. In the middle is the asthmatic airway. So you see that you have swelling going on in there already, and then outside is your smooth muscle that's kind of constricting. And then here it is during the attack, it's even worse. So now that area is even smaller for you to get air through. On this slide, it also says that, people can get to the point during an asthma attack, if it gets really bad, that they can actually go into respiratory acidosis. So you kind of feel like, in a way, you have trapped air. Like you can't get that air out all the way because, if you have air back here in your alveoli and you have all of this, swelling and things going on, you just can't get it all out. So it feels awful for that person. When my son had his issue with asthma, he was having he had kind of vague symptoms, but he just felt like his chest hurt. And that's kind of what he was complaining about. And then occasionally he would have a cough or whatever. It's not that we really heard a lot of wheezing and stuff like that, but just kind of slight symptoms. Okay, so when you are doing interventions for someone who has asthma, so if they're having an attack, one of the first things you want to do is make sure they're sitting up in a high Fowler's position because, just like we've talked about numerous times before, if you're sitting upright, it helps you expand your lungs better instead of, being all hunched over and stuff. You're also going to give them oxygen. We want to keep their oxygen sat between about 95 and 99%. We also want to get a baseline set of vitals, when they're first having their attack to see where they're at. And then we're going to first reach for a bronchodilator. So a bronchodilator is a medicine that's going to open up those airways. So how we said that you have all of the swelling and all of the airways are kind of clamping down? By giving this bronchodilator, it's going to open that up a little bit so you can move air easier. And so typically that's going to be albuterol that we're giving. If this is someone who had a really bad attack that was actually admitted to the hospital, if you couldn't get them under control with a bronchodilator, sometimes they'll give them epinephrine even. And then while they're there in the hospital, they may put them on a corticosteroid just for a short period of time to help get some of that swelling down in their airways. And again, if this is like a super bad attack, you may see this person get intubated even. Okay, so we talked about how there's certain triggers that can set you off into an attack. So if we wanted to prevent an asthma attack, then there's certain things that we could possibly do. So as far as prevention goes, you need, like if you have a family member with asthma, you need to keep your house very clean. So try to do a lot of dusting, make sure you don't have anything like that around in the house. If you have animals, animal dander can set someone off. So you want to totally, maybe you get a hypoallergenic animal. There's different breeds of dog that are hypoallergenic and stuff like that. If you are doing lots of vacuuming, some of the vacuums now have those HEPA filters, to try and get some of that bad stuff out of the air. Air purifiers are good. They have a lot of special types of bedding that you can get. I don't know if you guys have ever looked at that when you've been at the store. We probably all haven't been to the store in forever because of this coronavirus. But when you go look at bedding, they actually have stuff for people who are allergic to a lot of things. Like there's a a cover that you can put over your pillow. And then after you put that cover over your pillow, you put other things over top of that to try and like keep you from, getting to some of these allergens. You can do this with your mattress. There's all kinds of crazy things you could do. So those would be some things to think about. And then if this is a person who has really bad asthma, so like I would say if they had moderate to severe asthma, this is someone who should keep track of it religiously with a peak flow meter. Has any of you heard of a peak flow meter before?
Is that what shows like your maximum like inspiration volume kind of thing?
I'm sure you've probably seen like a respiratory therapist doing this before, Brandon.
Okay,
So
probably.
it's typically a little white meter that's probably maybe this long. And the patient basically puts their mouth around the mouthpiece, and then respiratory will say, blow out as hard as you can. So you just go and blow out as much as you can. And then there's a little indicator on it that will move up or down compared, from how much they blow into it. And that's the number that you're looking at. So the peak flow meter is just this handheld device that measures how well your air moves in and out of your lungs. So if you're someone that has moderate to severe asthma, you should be measuring your peak flow once a day. Usually you do it in the morning before you take your asthma medications. Or if you're having lots of episodes lately for some reason, then you would do it more often. But basically, you're looking at this reading. And if this reading is below 80%, that's not good because we want 80% or above. 80% or above means that we're doing well, that we're breathing fine, we're not having asthma symptoms. So if your number that you get when you blow into that in the morning is lower than that, then you know you're having issues. So there's something you need to do. So the peak flow meter is very instrumental in someone who has asthma to try and keep better control over it. So there's something called an asthma action plan that everyone should probably have if they have asthma. So like when my son had his issue years ago, we were supposed to have one at the school. So typically like you have this for your kid at the school so that if your kid has an asthma attack, they know what to do, for what's going on. When you look at an asthma action plan, it has 3 zones to it. So it has a green zone, it has a yellow zone, and it has a red zone. So the green zone is where you want to be at. So that says, hey, my peak flow is 80 to 100%. I'm doing good. I'm not having any asthma symptoms or problems. When you go to the yellow zone, that's when you're starting to have problems. So now your peak flow is about 50 to 80%. And typically your asthma action plan will tell you what to do from there. So it'll say, okay, if your peak flow is this and you're having this symptom and this symptom and this symptom, then go ahead and take your quick acting inhaler. It'll tell you what to do. So this person would go reach for their albuterol inhaler to see if that would help their symptoms. And then it kind of gives you more directions from there. So that's the yellow zone. The red zone is where we definitely don't want to be at. So this is where if you did your peak flow, it's below 50%. And this person typically has been having a lot of issues. So at this point, you want to reach for your quick, acting medicine, but you also want to call your physician or go to the ER at this point, because now you're like really having a hard time breathing and it's just a lot worse. So you definitely don't want to wait too long to do some of this stuff because you can be in bad shape. So this action plan tells you everything about what to do. It spells everything out. So the physician is the one that fills it out for you. And then so many people get copies of it. So like if I was the person with asthma, he would give it to me. I would make copies of it. Maybe I would bring it to work. So it was on file at work. Or if it was my kid, I would send it to the school, just so people have direction about what to do with your asthma. That's all it is. Okay. The other thing we need to talk about a little bit is some of the medications that have to do with asthma. So whenever you get questions about this, typically the questions are going to be like, okay, this person's having these symptoms. What kind of medicine should they reach for to take? So those kind of questions are trying to test to see if you know the difference between what's a short acting and what's a long acting medicine. So you need to like really look at these meds and make sure you understand the difference. So with short acting medicine, we're talking short-term beta-2 agonists. This is your quick relief medicine that you would reach for in a situation like this where you start getting really short of breath. So there's not a big list of those meds for that. So typically it's your albuterol, that's your main thing. But albuterol has like 3 million names to it. So I'm going to read off a couple other ones that you can write down. ProAir is one of them. Proventil is another. Ventolin is another one. And Zopinex is another name for a short-acting med. So again, you know, if you've ever heard that someone has a rescue inhaler or something like that, that's what they're reaching for, is that short-acting beta-2 agonist. So the long-term beta-2 agonists, this would be something that a person takes daily. So if I know that I have asthma and I constantly have issues with that, maybe I need to be on something daily to kind of keep that at bay. So your physician would be the one to decide that, you know. But the long-term beta-2 agonists would be things that end in OL. So formoterol, salmeterol, and there's even an albuterol tablet that would fall into this category. And I guess it's called Vospire, Vospire, and it's an extended release tab. So those things would be something that you would take daily to kind of keep this at bay. So if you were having an episode of shortness of breath, you would not reach for this first because this is not going to help you quick like your short-term one would. All right, and then there's other medications too that you know, your book mentions a little bit. So there's a lot of different combination medications out there. So a lot of different inhalers like Symbicort, Advair, Dulera, Anoro. Some of those are combination medicines. So this means that they have two different things in them. So they would not be something that you would reach for in an emergency episode if you had shortness of breath. Again, these combination meds would be something that you would take daily. So I put a bunch of stuff in here as well in this PowerPoint about these meds. I also mentioned anticholinergics in here. Those would be something that people might take as well. Anyway, so you guys can read through all of those. I don't want to read all of that to you. Any questions about asthma? If you guys go into your, I think it's in your discussion board. I think that's where I put it. So normally when we're in class on ground, I give you an asthma action plan and I have you fill it out according to like this scenario that we have. And it's just kind of nice to see what it looks like and what it is. So I think I put that on your discussion board. So make sure you go look at that because I think that would be very helpful. All right, the next thing we're going to talk about is COPD. So COPD is kind of complicated. I'll just put it that way. So COPD stands for chronic obstructive pulmonary disease. And this is kind of a group of diseases that is grouped together to cause this. So what it is, it's chronic inflammatory lung disease that causes an obstructed airflow from the lungs. So it's making you hypoventilate. You're not able to breathe as well as you were before. So there's two specific things or two disorders that kind of make up COPD. A lot of people talk about bronchitis and emphysema. So these things, a lot of times those two things together will be COPD. Like you'll see someone who has symptoms of both and they have that. So what happens with COPD is that your airways and your lungs become inflamed, just like they do in asthma, and they thicken. So in asthma, they don't thicken. So that's something different. Your lung tissue, where the oxygen is normally exchanged, is destroyed. So down towards where the alveoli are, where you have that exchange of gases, that gets really messed up in COPD. And you can't fix that. So as a result, the flow of air in and out of the lungs decreases, and then your body has a more difficult time getting rid of CO2. You hang on to that more now because of this. So basically, you have damage that happens to your lung that you cannot fix. COPD is something that you live with for the rest of your life. You cannot be cured from it. And then I'm going to tell you some possible causes, things that could contribute to this. So the number one thing is smoking. So smoking is going to be your biggest problem. And usually most people who have COPD seems like they still smoke anyway, and they just have all kinds of issues. Other things that could contribute to this, your environment. So if you live somewhere where there's a lot of pollution or something, that's a big deal. Secondhand smoke, dust, fumes, and chemicals, all of those things can affect your lungs. And then there's also something called alpha-1 deficiency. So this is a genetic inherited condition that affects the body's ability to produce alpha-1 protein. And alpha-1 protein is something that protects the lungs. So if you don't have it, if you're deficient in it, then you would be more apt to get COPD. Okay, I'm going to show you a couple of pictures that I have on here. And again, remember I said, bronchitis and emphysema, they kind of both make up COPD. Sometimes people will have more symptoms of one than the other, and sometimes people have both at the same time. It just varies person to person. So when you talk about this, if you talk about emphysema, if you think of it like the pink puffer, so this means that this person, they retain their CO2 more now. They have a hard time getting rid of it. Because remember when we talked about the pathophys, we said that that area where you have that gas exchange is really destroyed and messed up from all of their exposure to smoke or whatever that caused their COPD. So now they're hanging on to all of the CO2. So this means that they're not ventilating really well. So this person usually has a lot of shortness of breath. They're orthopnic, which means that if they lay down flat, they can't breathe. So in order for them to breathe well, they have to be sitting up to breathe. Other things that this talks about is the barrel chest. So barrel chest is something that you totally will see with someone with COPD. The typical person who suffers from this, they're going to have like this upper portion of their chest is going to be like this, and then the lower portion will be a little bit flatter. And the reason that people get this is because they have trapped air in their lungs. So someone who has this, they can't have all that good gas exchange like they normally do. They have air that is stuck in there. So they're constantly hyperinflating their lungs without, deflating them all the way. So over time, that just causes your rib cage to stay that way. And that's what makes you have the barrel chest. This person, like I said, they're very short of breath all the time, so they speak in short, jerky sentences. They're usually really anxious, and they use a lot of their accessory muscles to breathe. So that's the emphysema. The bronchitis, this person, if you see someone that has more of these symptoms, it's usually because they have an airflow problem. So this is the person who their biggest problem is their inflamed airways. So because they have all this inflammation going on, they're really not getting good airflow through their lungs. And so they're going to actually look like they're cyanotic. So that's why they call this person the blue bloater. Usually they have a big time cough and they produce a ton of sputum. They're always hypoxic. They have an increased respiratory rate, and usually they'll have that clubbing at the end of their fingers. And then over time too, something that you could see from someone with COPD, they're going to have an enlarged heart, and this could lead to right-sided heart failure. All right, and then here's just a couple other things I put here for signs and symptoms. So a lot of times they are very fatigued, they have a lack of energy, they're not able to tolerate much activity, they a lot of times have really poor nutrition, so sometimes you'll see someone that's really thin. A lot of times too, because they are so short of breath, you'll see them like sit in that tripod position, which basically if they were in the hospital and they had that rolling table, that they have, usually they sit on the side of their bed with that rolling table and just like go like this. So they're hunched over a little bit because it helps them breathe better. They feel better in that position. So it's not that this is an intervention. So like I see a lot of students think that's an intervention to do for someone with COPD, that it's going to make them breathe better, but it really doesn't. It's just something that they think makes them breathe better by sitting that way. Other things, let me see if I missed anything. A lot of times you'll see wheezing with them. And then they are more at risk for lots of respiratory infections. So a lot of times you'll see people come in for a COPD exacerbation to the hospital, and usually it's because they have some type of respiratory infection that they got that caused them to kick off into their exacerbation. So they're very at risk for that. All right, some ways that you can diagnose COPD would be a pulmonary function test. Part of the pulmonary function test is doing a spirometry. And this is where you blow air into a mouthpiece with tubing attached to it to some type of machine. And the machine measures the amount of air you blow out and also how fast you can do it. And then a couple other things that you could do for to figure out if this was it or not would be, you could do a chest x-ray. You could do an ABG to see, if they're super hypoxic or not. And you could also do a CAT scan just to look at their lungs. So some things to do for interventions. So typically, a lot of times these people are on supplemental oxygen. So you have to watch, though, how much oxygen you give this person, because a person with COPD, what happens if you give them too much oxygen? Do you guys know?
Is it harder for them to breathe?
Well, kinda. What did anyone else have a thought?
I don't
before?
remember. I mean, I know it's bad, but I don't remember what it does.
Okay, so this is the deal with that. So if, like, say I have a COPD person that comes in with an exacerbation, at home they're normally on 2 liters, but then when you get them to the hospital, their SAT's kind of crappy. So you, even with 2 liters on, they're just bad. So you turn them up, and you turn them up to like 6 or something. So what this does is it causes them to not have, what am I trying to say? Let me see if I can put this the right way. They need some kind of trigger to trigger them to breathe, okay? Because they're already having all this trapped air and having such a hard time moving air in and out of their lungs. They live at a low SAT, and that's okay for them because they need that trigger, you know, that low SAT to get them to breathe. So when we turn the oxygen up too much, it decreases that trigger to get them to breathe. So they tend to not breathe as much, and they can end up going into respiratory distress and like totally like have respirations that are really slow and low. So it can really cause a big problem. So we like to keep their SATs between about 88 and 93%. So if they're okay at 88, we are fine with that. Does that make sense? I hope I made sense when I was trying to explain that.
Yeah, so I have a question.
Yeah.
Is that what, I know we don't know for sure, but is that what it's kind of going on with everybody being placed on ventilators during this respiratory COVID problem? That if they're being placed on the ventilators, they're not giving their body a chance to breathe on their own, so it's ruining their lungs?
No, I don't think it's that.
Okay.
Yeah, I think it's something totally different with that. I know that is kind of interesting. It makes you wonder what's really happening there, but I don't think it's that. I think this is something different.
So this is just with COPD?
Yes.
Okay.
Yes. Also, in your book, when you do your reading, they do talk about oxygen toxicity as well. Now, I wouldn't worry too much about this type of person being toxic with oxygen, but you could have that. So if someone is toxic with oxygen, they can get actual like chest pain and like some weird symptoms that go along with it as well. So you want to keep a person at a pulse ox to where they're feeling okay, but they're not having like symptoms like that, you know? Other things that we could do for interventions for someone with COPD, pulmonary rehab is a really good thing. A lot of times pulmonary rehab will do quite a bit for the person. They actually do education about how they should eat. They can do smoking cessation stuff with them. They do physical reconditioning, psychological support, all kinds of stuff. But the whole thing with them is it helps them improve exercise capacity, and it helps them have a better quality of life. They do a ton of things with them. So pulmonary rehab is really good. Of course, we're going to give these guys medications on a daily basis to kind of keep their COPD okay, you know. Obviously, we can't ever get rid of it, but we can live with it and maintain it at a decent level, you know. Believe it or not, there are surgeries that you could do for COPD. So one thing that I don't know if you've ever thought about, but there's something called lung reduction surgery. So if you think about it, what happens with COPD is you have a part of your lung that is not working well. It may not be your whole lung, but it's part of it, right? So if they could pinpoint where this is at, they could remove that portion of your lung, and then you still have the rest of your lung that's healthy and doing okay. And then maybe you'd have better exercise capacity because that part is gone that was so diseased. Kind of a weird concept, right? The other thing, for surgery, you could always do a lung transplant if you had to as well. Now, when people get to a certain point with their COPD, over time, sometimes they get to a point where it's pretty bad. If they're like end stage COPD, then they may be, palliative care at that point. So we want to get this person to the point where they can, live their day-to-day life and be, functional and to not have such a hard time every day. So some of the medicines that we use would be very similar to what we just talked about with asthma. So these guys are going to have a short-acting bronchodilator as well. So they would have like an albuterol inhaler or something that they could use in an emergency if they needed to. Also, they have long-acting drugs that they do as well that they could use every day. So they probably have, different breathing treatments or inhalers that they do daily as well. Because these guys have such a hard time with inflammation, if they are admitted to the hospital, for an exacerbation, they may put them on a short-term dose of corticosteroids to help with that inflammation. And then I do want to mention 2 other drugs that are specific to COPD. So there's one that's a phosphodiesterase 4 inhibitor. And I'm going to spell it because I don't know how to say it right. It's ROFLUMILAST. And this is a medication that you see people with really severe COPD take daily. And then there's an older medicine that you may kind of remember from pharm, I'm not sure, but theophylline is a medicine that we used to use a long time ago, a lot more than we do now. But theophylline, it's a pill that you take, and I want to say they take it twice a day. But the reason that we kind of have gotten away from that is because it has a lot of bad side effects, and you need to have blood levels drawn. And the blood level it's one of those type of meds where if you don't have enough of it in your system, it's not going to work. But if you have too much of it in your system, you can be toxic from it. So you have to be within a certain range to be on that. So it's not the optimal thing for everyone to be on. So you don't really see a ton of people on that anymore, but you should still know about that med. Okay, a couple other things I just want to mention real quick about COPD. There's 3 different interventions that I would write down a little bit about. Pursed lip breathing is one of them. So this is an intervention to make breaths more effective and intentional by slowing them down. And the benefit is it would help relieve shortness of breath. If you were like super short of breath and you started to do this, it would like slow everything down and make you feel a little bit better. It also helps keep your airways open for longer. And it improves your ventilation by getting rid of the old air that you have stuck in your lungs and makes room for new air as you breathe now. And I'm sure we all have seen someone try to do pursed lip breathing before. When you're trying to teach someone about it, you try to tell them about, hey, you're trying to blow out a candle, so you purse your lips like that. So that's kind of what you would do for that one. There's another one called diaphragmatic breathing. And this all has to do with your diaphragm. So what this does is it helps retrain your diaphragm to work more effectively. So typically, especially a COPD patient, usually they're so short of breath all the time, they're constantly using all their accessory muscles when they breathe. So diaphragmatic breathing focuses your breathing more on your diaphragm. So you actually lay down when you do this and you put your hand on your stomach to kind of be more aware of what's going on there. So that's another good intervention for someone with this problem. And then I'm sure you guys have heard of huff coughing before, right? So huffing or huff coughing is an exercise to help you cough up mucus more effectively without making you feel super tired. So like if you don't do the huff coughing and you just do a regular cough, it takes a lot out of you. So if you do it the right way with this huff coughing, it conserves some of your energy and still helps you get mucus out. Okay, any questions about COPD? On this slide here too, I was talking a little bit about like nutrition wise, people need to eat high calorie, protein rich meals that are small but frequent to stay hydrated. Because remember, these people are very thin and they don't eat well. So if they eat more often throughout the day, but high calorie things, it's hopefully going to help them more. They need to avoid being around anyone who's sick, any irritants or hot, humid, or very cold weather, because that could set them off into an exacerbation. And you know, you really want them to stop smoking if at all possible, but it seems like every COPD person I've ever seen still smokes. Other things, you would want to make sure their vaccinations are up to date, because you're trying to keep them from getting sick, because the more times they get sick, the worse it makes them feel. Okay, so the next thing we get into a little bit is pneumonia. So remember, pneumonia is a lower respiratory tract infection. So when you get pneumonia, typically one of the things that happens before that is atelectasis. Atelectasis is kind of a precursor to pneumonia. And usually if someone gets pneumonia, like say after surgery or something, it's typically because they're not taking deep breaths and they're not doing their incentive spirometer and that kind of stuff. So they can get certain symptoms, and then over time that's going to worsen, and then they'll end up with pneumonia. However, there's other ways to get pneumonia as well. So basically you get a germ that gets into your lungs either by inhaling it, by aspiration, or from the blood. You know, like you could get a bloodstream infection that ends up into this. So what happens is you get like these fluid-filled alveolar sacs. And because you have all this fluid in your alveoli, it's making that gas exchange not be so good anymore. So you typically are hypoxic when this happens. Like you can't get rid of all of the carbon dioxide and take in the new oxygen because all of this fluid's in the way. So this person could end up having respiratory acidosis. I don't know if you guys remember much about our ABG stuff that we did a while back, but when we talked about respiratory acidosis, we said this is something that affects how they are ventilating, something that's making them not breathe as well. So typically their oxygen level is low and they can't oxygenate like they should. Okay, so this is something I want you to pay attention to. So there's a difference between community-acquired and hospital-acquired pneumonia. So community-acquired means that the person gets this germ from outside of the hospital system, in the community somewhere. If it's hospital-acquired pneumonia, this means that, like say maybe I came in for a broken hip or something, and I'm getting hip surgery, but then 48 to 72 hours after I get admitted and after I've had my surgery, now I'm starting to get symptoms like I have pneumonia. So this means that I got it in the hospital. So your criteria is 48 to 72 hours after admission. So when I came in, I didn't have any of those symptoms, but now I do. The other two kinds of pneumonia are ventilator-associated pneumonia and also aspiration pneumonia. So ventilator-associated pneumonia, this is why we try to get people, you know, to not be intubated for very long anymore. So we found over time that the longer someone is on a ventilator, the more apt they are to get sick. So they can end up getting bacteria that travels down that ET tube into their body, and that's going to cause them to get pneumonia. So one of the things that they have learned, with evidence-based practice is brushing someone's teeth while they're intubated is very helpful. If you can get some of that bacteria and plaque and stuff away from that ET tube, that totally will help prevent this. So I know it's hard to imagine trying to do this in someone who has all this, that can't spit or do anything as you're trying to brush their teeth. But those green swab things that they have in the hospital, they have a certain thing that you can hook up to the suction on the wall. It looks just basically like a basic green swab, but you use that to brush their teeth. And then any kind of secretions that you have in there, it'll suck it out because you're hooked up to the suction on the wall. So it works pretty well. Aspiration pneumonia is something we're always worried about with older adults. If someone is having a hard time swallowing or, they're coughing a lot while they're eating, we're worried that something's going in the wrong place. It's not going where it should be going. So that could be something that you might see as well. So something I want you to pay special attention to in signs and symptoms. We all know basic signs and symptoms of pneumonia, but with older adults, so look at the number 2 thing here. So older adults may look different when they have pneumonia compared to someone else. They're going to have neuro changes. So they may not have a fever, but fatigue and increased respiratory rate. They may not have all of that kind of stuff. They just may get confused all of a sudden, So they present differently. The normal person with pneumonia, they may have a little bit of a low-grade fever. They can have a cough. Sometimes they'll have an increased heart rate and respirations. They may have elevated white blood cell count. They could have pain in their chest when they're coughing. You could hear crackles in their lungs, you name it. So some of the things that we do to help with this, with interventions, we definitely push that incentive spirometer. The reason for this is the incentive spirometer, when they do this the right way, it helps pop open those alveoli. So when we're filled up with all of this fluid in there and our alveoli aren't working right to get that good gas exchange, the incentive spirometer definitely helps with that. Other things that we do, of course, we're going to encourage lots of fluids unless it's restricted for that patient. We want to make sure everyone's up to date with their vaccination. So that's the number 1 way to prevent pneumonia is to be vaccinated, And then also keeping the head of the bed elevated a little bit, doing breathing treatments, probably giving antibiotics. And then also chest percussion. So I'm sure we've all seen someone before that's had a really hard time getting secretions and stuff up when they cough because they're so bad. So a lot of times if you do chest percussion, bang on the back of their chest with your hands in certain places, it'll help loosen up that mucus so they could cough it out or you could suction it out easier. All right, any questions about pneumonia? Okay, I'm going to keep going then. All right, so this is something that most people have a hard time understanding. So I want you to make sure you particularly pay attention to ARDS. So after we have lecture here and you're off of here, go watch the video that I have posted on this because I think it will help you understand it more. All right, so what this is it's someone's in respiratory distress when they have this, right? But this is a different type of respiratory distress than just the regular kind. So what's going on here is that the capillary membrane that surrounds your alveoli, it becomes damaged because of something that happens to you. And so this causes fluid to leak into the alveolar sac. So you get impaired gas exchange now, just like we talked about with some of those other things. It's pretty similar, right? So when you can't have that gas exchange that happens between your alveoli and the blood, you're gonna end up being hypoxic, right? And so, like this is saying here, if you have fluid in the alveolar sac, your alveoli are going to collapse a little bit. They're not going to pop out like they normally should be. And they're going to cause a decrease in lung compliance. So our lungs should be compliant, meaning that when we breathe in and out, they should do it nice and smooth, right? So if they become stiff or elastic, they have a harder time moving back and forth, right? They become really stiff, so they have a harder time doing that. So this person, we see that they're hypoxic, so I'm sure we'd probably give them oxygen as a result. But the thing is, that's not going to help here in this person. Let me talk a little bit about some of the causes of ARDS. So there are indirect and direct causes. So indirect causes mean that it's something that has nothing to do with your lungs. So maybe this person has an episode of sepsis that causes this to start to happen. Or maybe they had a really bad burn, or maybe they have pancreatitis really bad, or a drug overdose or something. Those are indirect causes. Then direct causes would be something that happens to your lung itself that causes you to go into this. So like, how we just talked about pneumonia. So that could have been a cause. So your pneumonia got so bad that it caused you to go into respiratory distress, and here you are. Aspiration, inhaling a toxic substance, a significant drowning event, and even an embolism could cause this. So my mother-in-law actually had this happen. It was really scary. This happened a few years back. So she had an episode of sepsis, and it was the craziest thing because she normally is very healthy, not too many problems. But anyway, she had an issue with her heart where she had to go to the hospital, and she got cardioverted. She was in irregular heart rhythm. So this was an outpatient thing, no big deal. She got cardioverted. They put her on a new medicine. So she comes home, and she felt funny really for a couple of weeks after this. And she just thought that it was the new medicine she was on. So she kind of poo-pooed her symptoms, and she really didn't have a whole lot of symptoms. She just felt like kind of washed out and tired and stuff. So then probably 2 weeks went by, and then she woke up one day and she was confused. She was short of breath, and she just looked awful. She's not normally confused, and she just looked horrible. So they called 911, and they came to the house to get her. And then on the way to the hospital, she coded. She ended up, they brought her back, of course, and, they get her to the hospital, and she was super sick. We had no idea what was going on with her. So she ended up getting on a ventilator right off the bat, right when she got to the hospital. And then she was in the hospital forever. So they had to try and figure out what caused this. They're like, this is definitely sepsis. After they drew blood and looked at some things, they knew it was sepsis, but they weren't sure what caused it. So it turned out that it was a pneumonia that she had that caused it. They tested all of these different things, and that's what it was. But so this was a horrible thing. So she went into this ARDS. So something that you see happen with this, let me see if I have it on the next slide or not. Oh, yeah, this kind of talks about it. Okay, so anyway, what happens is, like we talked about the alveolar sac filling up with fluid and collapsing, right? So you're not getting that good gas exchange. So even though this person is hypoxic and you put them on oxygen, it doesn't help. So normally when someone is hypoxic and you put them on oxygen, sure, their oxygen sac comes up and it gets better. But refractory hypoxemia means that no matter what you do, you can have them on 100% oxygen, it's not helping. So that's what was happening with my mother-in-law. So anyway, they have that decrease in lung compliance. So your lungs aren't stretching like they should to, breathe like they should. Your surfactant cells are damaged. So you have decreased surfactant production. And I don't know if it's on, yeah, here it is. So the other thing that you see, like if you catch this early on, of course you wouldn't see this just yet, but eventually, like by the time they got my mother-in-law to the hospital and they looked at her, when they did a chest x-ray, she had whited out lungs. And that's what this says down here. So that's like really specific to this. So like if you would have done a chest x-ray a few hours before, then it wouldn't have looked like that. But this happens super quick.
What would be white in the lungs?
So this means, how we said you have all that fluid that comes into your
So it's just
alveoli?
like excess fluid.
Yeah, it's all of that fluid. And so it happens super quick to where, sometimes when you look at someone's chest x-ray, you'll only see a little portion that has white in it. Well, this is like completely whited out all the way in both lungs. So when someone has this, then they're going to be tachypnic, they're going to be breathing fast, they're going to be hypoxic, they're going to be cyanotic, low oxygen sat, mental status change, tachycardia, using all of their accessory muscles to breathe, crackles throughout their lungs, and that whited out chest x-ray. So it's going to be awful. All right, so what do we do for this? We immediately put them on mechanical ventilation. So like I said, my mother-in-law got intubated right away. She got put right on there. So what they do is they put you on this setting called PEEP, which is positive end expiratory pressure. And the way this is set is that it helps open up those alveoli so that you get a better gas exchange. Other things that sometimes you'll see in a question about this would be a lot of places will tell you to do prone positioning. You remember back when we talked about orthopedic stuff and we said, like for someone who had an amputation, we wanted to put them on their stomach for a little bit to kind of help prevent those contractures. Well, in this case, this person, if you put them on their stomach, like if you had a special bed that did that, it's going to help move some of that fluid up, so you can get it out of their lungs, right? So that's kind of the whole purpose of that. But basically with this, it's kind of a waiting game. You treat whatever the underlying cause is, right? So like with my mother-in-law, it was the sepsis. So we're treating the sepsis. We leave them on the mechanical ventilation for a little bit, to get them, to get their lungs better, and then we'll take them off. But you're going to treat all of their symptoms, basically. So again, always mechanical ventilation. That's your number one thing you're going to do, because no matter what you do, whatever oxygen device you put on them, it's not going to help. This is the only thing that will help them. So you'll do that. You do the prone positioning, and then we try to prevent other complications from happening because this can snowball. So as they're on this mechanical ventilation, you can end up getting pressure injuries. You could get blood clots. You could get, ventilator associated infection. There's 3 million things that could happen. So you're trying to ward all of that off while, trying to fix their lungs and whatever the underlying cause was. So it's very scary. I hope that made somewhat of a sense. I don't know. When you watch that video, I think it'll be a little bit better. That lady on that video is pretty good at explaining it, I thought. Questions?
Nope.
Okay. All right, we've got like 15 more minutes before class is done. So I'm going to see if I can end with this lung cancer stuff. There's just a little bit left here, I believe. Okay. So with lung cancer, if someone gets lung cancer, usually it's just this group of abnormal cells that starts to, form inside your lung somewhere. And as it gets bigger, it ends up being like a bigger tumor like, and ends up invading other spaces and stuff as it gets bigger. So anyway, causes for lung cancer would be things like smoking, passive smoking. So if you weren't really the smoker yourself, but you were around it secondhand, asbestos exposure, if you had radon gas exposure, if you had previous lung disease, like maybe I had COPD for so many years and now I have lung cancer, who knows? Prior history of lung cancer, so maybe you were cured from it before, but now you have it again. Air pollution. And then also you could get it from just having it run in your family, you know, family predisposition. So there's different types of lung cancer. There's like a lot of different types, honestly, but I'm going to talk about it like this. So, and I'm not going to flip through these slides. I'm just going to talk to you here. So with the types, I want you, if you're drawing this in your notes, I want you to have two different offshoots here. So there's a small cell lung cancer and a non-small cell lung cancer. So small cell lung cancer is about 10 to 15% of all cancers. So it's not like a huge percentage. It also can be called oat cell cancer. And the problem with this type of cancer is that about 70% of people, when they find out that they have it, usually it's already spread by that point. It grows very quickly. However, it does respond well to chemo and radiation. So that's small cell lung cancer. Okay, the other one, non-small cell. So this would be the bigger percentage of the other cancer. So 80 to 85% of all cancers would be this, you know, out of lung cancers. So there's 3 types of non-small cell cancers that I'm going to talk about. So, you know, do another like 3 offshoots off of that. The first one is squamous cell. So the squamous cell cancer is, it starts in the squamous cells. And these are cells that line the airways of the lungs. Usually this is linked to smoking, and it tends to be found near the main bronchus. Then there's adenocarcinoma. So adenocarcinoma is usually found in the outer portion of the lung. So the nice thing about this one, because it's found in the outer portion, it's more likely to be found before it spreads. And this is mainly found in current or former smokers. And then the third one is large cell carcinoma. So that's the third type of non-small cell. So this one can appear in any part of the lung. It tends to grow and spread very quickly, and it's harder to treat. Okay, so when someone has lung cancer, some of your signs and symptoms you'd be worried about. Things like coughing up bloody mucus. If you have a cough that changes over time, so like maybe it's a dry cough at first, but now it's different. If you get shortness of breath that you can't seem to get rid of, that gets worse over time. You could have chest pain that lasts for a long period of time, hoarseness, wheezing, a loss of weight, and also fatigue. So to diagnose this, and I've seen this 3 million times, so there's a lot of people who come in for another problem, totally unrelated, and then they'll get like a chest x-ray or something, and lo and behold, they find a lung cancer. Like it's a secondary finding. So a chest x-ray could definitely see something. If you did see something worrisome on a chest x-ray, then you would send them for something more diagnostic like a CAT scan, because that's going to show more detail. And then if you were sure that, yes, this was a tumor, then you would want to do a biopsy, right? So you would want to do a lung biopsy. And there's a few different ways that you could do that. So as you could see, you know, some of these different types of cancers are located in different spots. So like if I did a bronchoscopy is an endoscopy where I actually put, you know, the thing down this person's throat and I go down towards their lungs that way. Now, if this was one that was on the outer portion of the lung, then sure, maybe that's the way that I need to go to get my lung biopsy, right? But if this was more like towards the inner part of the lung, like, you know, towards the main bronchus or something, then maybe that wouldn't be the best way. So then you'd have to do it differently, right? So there is a surgery called a mediastinoscopy where they actually open you up to go in to do the biopsy. So that would be something that maybe they would do. And then I don't know if you guys have ever seen someone that's had a thoracentesis before, but when you have like a collection of fluid around your lung, in that space between your lung and the outer portion of your lung, sometimes that fluid that collects in there has cancerous cells in it. So you could actually do a thoracentesis and send that fluid off for testing, and then that might tell you something. So as far as treatment goes, if we're talking about non-small cell, like the one that we were just talking about, your treatment is going to depend on the stage of your cancer and the person's overall health and function. So I don't know if you guys knew this or not, but with staging for cancer, did you know there was a stage 0?
Stage 0, never heard of it.
Isn't that funny? I never realized that until my mom had breast cancer a few years ago and she had stage 0. And I'm like, I didn't know there was such a thing. I always thought it started with stage 1. But there's a stage 0. So anyone that's stage 0 to stage 3, if you have non-small cell cancer, they may do surgery for you to get it out. And then anyone with stage 4, if you're at stage 4, this means that your cancer has metastasized to other places at that point. And so, you know, surgery is not going to be helpful here. So usually with non-small cell cancer, they would do other things at that point. So maybe chemo, radiation, targeted therapy, or maybe even palliative care if that was what the person wanted at that point. With small cell cancer, so remember when we talked about this a few minutes ago, we said that this is usually found after it's already spread, which is bad, you know? So this is usually going to be treated by chemo and radiation. So you wouldn't need to do surgery here either because it's already spread everywhere. So you're not going to do any good with that. So chemo and radiation would be probably the thing you would do. And then next time we meet, we're going to talk about some of the types of surgeries that they would do and stuff. So it'll make a little bit more sense. Did you guys have any questions?
I don't have any.
So for those with the adult 2 clinical, we have to do one of those shadow thingies this week, right? Or
Yeah, it doesn't take very long. It's pretty simple.
okay.
So for you, you have clinical tomorrow?
Yes.
Okay. So tomorrow you basically have an orientation for shadow health that you need to do. It's like orientation pharmacology or something right at the top. And then you also have a concept lab that I want you to do that has to do with asthma in there.
And I think we still have to do that orientation thing for VSIM. Even though I already did a few VSIMs, I think I still have to do that orientation thing.
So this is the thing. I told the other groups, you don't have to do an orientation for that stuff. If you feel good with it, I'm fine with she doesn't have you do that. So you can tell her I said that.
Okay.
That's fine. But the other, so there's like 3 things that you're responsible for doing this week in clinical. So those 2 things I just told you about. And then the third thing is your DocuCare assignment that you have. So that Leela Castile made this DocuCare assignment for everyone at all the campuses to do. So that needs to be done.
Okay.
Okay. So obviously we have a lot of other stuff to go over, and we'll catch up next week. It'll be okay. So what I would do, I would make sure you go look at your reading. And then if you like that thing that I gave you guys, this paper, about making notes, you could do that. And then I'll post this recording and stuff too. I put answers to the math worksheet on your announcements too, so you guys have that. Okay.
Thank you.
All right.
All right. Thanks.
All right. You guys have a good afternoon.
Thanks, you too.